one of our early learning collaboratives. We had Emily come and talk to us about Charlie Health. They do have some updates. Again, one of the reasons we invited Charlie Health here is that they provide, and they're going to explain all of it and they've expanded their services, but they are a possible referral source for you all when you meet somebody in the community who's in crisis. There are some specific programs and things that they offer. They work with a lot of the private insurance and also serve youth and young adults. So I invited them here just so that we have, something in our back pocket in case their programs might be a good fit for somebody that you guys, for somebody who's experienced a mental health crisis that you guys run across in the community. So I'm just going to hand it right over to Emma and Emily to get started. And we are recording this. So, all right, you guys are up.
Thank you so much, Beth. I appreciate the introduction, and it's good to see everyone. I know I've met a few of you both in person and virtually, so thank you for sharing your time, and I apologize if some of this is repeat, especially Jackie. I know that we just met, so hopefully you gained something from this. But I know, folks, some of you were here the last time that I came to present. I'd love to start with just general overview of the program, but would love to hear any feedback and questions as we go. Is there anything specific or any questions that anyone has prior to me launching into our information that you want to make sure I cover, or any feedback that you want to share prior to us getting going here? Otherwise, we'll just jump into it. Okay, fantastic. Oh, Beth, was there something? I saw you come off mute.
Oh, I think you will cover this, but I think for these folks, it's just because it's crisis oriented would be, how do they access you quickly? What's the timeline? What do you, those types of things that they might be doing out in the field to connect somebody with you. So anything to streamline that process would be helpful.
Absolutely.
And then I already told you guys, but normally these are the folks that go out for the lifespan, and then we kind of talk about the 20 and under. But this is a mixed group that they can always take information back, because I know your programs go all the way through 30, I believe. So.
Okay, fantastic. Yes, I'll make sure to cover all that. And if questions are coming up as I'm going, feel free to stop me, or you can post in the chat. I have my incredible team member, Emma, here. Emma, if you want to come off mute and say hi and introduce yourself real quick, go for it.
Yeah, hi guys. I am actually located in Central Oregon, so I work Central, Eastern, and Southern Oregon counties. So if you happen to be in any of those, I'm always more than happy to connect and answer questions. But yeah, just here to kind of listen to Emily and help man the chat. So please feel free to put questions as they come up in there, and I'll contribute how I can. Nice to see everyone.
Okay, I'm going to go ahead and share my screen just to provide a little bit of a visual here. Let me make sure that I can. If you do have any questions, please post them in the chat or interrupt me like mentioned. Is there anything, can somebody come off mute and just tell me if you can see my screen?
We can.
Okay, fantastic. Good. On Teams, we're so used to Zoom, and on Zoom, I can see you folks, and on Teams, I can't. So if you have questions, interrupt me or post them in the chat. Emma can manage that. I'll just start with a general overview of Charlie Health for those who are not familiar or want a recap of what we do and kind of where we fall in the continuum of care. But we were created specifically to fill a gap in the behavioral health continuum of care. So we have these higher levels of care, 24/7 facilities, and then these lower level of care, more outpatient, once a week or bi-weekly therapy, right? Our CEO, Carter Barnhart, was working in a residential treatment center and had a difficult time discharging folks to the appropriate, not only level of care, but just accessible program that met the needs of the individuals she was working with. So she wanted to develop an intensive outpatient program that really met folks where they were at. So she created Charlie Health to be this accessible, affordable version of intensive outpatient that was fully virtual, so folks could join this more middle level of care wherever they were. So we were created to help with folks discharging from higher levels of care. So we see a lot of folks as they're coming out of emergency departments, residential treatment centers, and inpatient hospitals. But we also want to work more upstream and see folks prior to them needing these higher acuity resources. So we see folks who might just be having once a week or biweekly therapy, but need a little bit more support than once a week therapy. And that's where we come in. So we are fully virtual, focused on adolescents and young adults ages 11 all the way up to 34. So we have expanded our age range since I last met with your team, and now can support young adults all the way up to 34. And I'll get into some of our specialty programs, but one of our programs we're able to see a little bit older than that as well. First, I just want to cover our treatment and what it looks like to participate in Charlie Health. Everything you see on this screen right now is accessible from our clients. So that top row is really the bulk of our program. We, of course, being an IOP, the major focus and where the magic happens is in our supported groups. And I'll get into how we do things and what that looks like at Charlie Health here in a minute. But beyond the group therapy, every client has access to individual therapy. They have access to family therapy, which is strongly encouraged and a huge part of our program at Charlie Health. And then they have access to psychiatry and medication management as necessary. So if a client is needing medication management while in the program, our team can do that. So that top row is really the bulk of the program. The bottom row are additional supports that every client has access to as well. So every client has access to 24/7 crisis. They have care coaches available to them, which are similar to peer advisors, folks who are leading with lived experience. And then they have access to family support groups, which is one of my favorite pieces of our program, something that's really unique to Charlie Health. We have just a bunch of free support groups for family members every night of the week. So this is beyond the family therapy piece. This is for family members, whether that's a sibling, a foster parent, an uncle, or a best friend, whoever the client identifies as family is welcome to these support groups. And we have a whole list of them, but some fun ones we have a siblings group, we have a BIPOC family support group, we have an LGBTQIA+ one-on-one workshop for family members, and much, much more. So lots of options there. And then clients also have access to case managers and discharge planners. They have a discharge planner that's assigned to them to make sure that they have the resources set up and in place when they're ready to transition out of our level of care and into a lower level of care. I'll pause there before going on. I'll get into how we do our groups. Any questions about just the resources that we have in our program, in our IOP? Okay, we'll keep going. So at Charlie Health, we really believe that one size does not fit all, right? We're really big into creating customized treatment programs for each individual coming into our program. And what we look at is every client is going through an assessment prior to joining the program, right? And what we're looking at here is first, we take their age and maturity into account. So they'll always be in groups with other folks who are around their same age and maturity. But we're primarily looking at the condition that they're presenting and what modality is best going to serve that condition. And we're placing them in groups with other individuals who are, of course, around their age and maturity, but also have similar conditions and are working on similar goals. We also look at lived experience. So clients coming into our program can be in groups with other individuals who have a similar background to them and are able to relate to them. It's really important to us that we are creating these groups where individuals can come together and see each other in the other people in their groups, right? We all know the power of that Me Too, the power of identifying yourself and somebody else. And we see just really incredible outcomes from the way that we match folks with other folks from all over the country based on their unique needs, but also their background, their condition, and what's going to be best for them. So the way, and this kind of, Beth, goes back to your question of how do we get folks connected to Charlie Health? What does that referral process look like, and how quickly can they access our program? We do not carry a wait list, so we have immediate availability for clients. Once a referral is sent in or called in, we schedule their assessment. We do a biopsychosocial assessment for the clients, and we can usually schedule that either same day or within 48 hours, given that the availability we have matches with the client and family availability. We can even do these assessments prior to clients discharging emergency departments or inpatient hospitals to help minimize the gap in care. So that way, if they're transitioning from a higher level of care, they can immediately access our program and step right into Charlie Health after discharging from whatever level of care they're coming from. So the referral comes to us. We schedule an assessment with the client and the family. And then the client is able to admit directly after that assessment. If it's an insurance plan we need a pre-authorization for, it might take a week or two depending on the insurance plan, but typically we're able to just immediately admit clients after that assessment depending on the insurance. Once clients start the program, they have an individual therapist that's assigned to them based on, again, their unique needs, what condition they are presenting with, and what modality is best going to serve that condition. We are matched with a therapist that specializes in that. They're also matched into a group with other individuals. Usually these groups are about 4 to 8 individuals, so they're small. And they see these groups 3 times a week for 3-hour sessions where they're doing a combination of evidence-based therapy and contemplative and experiential modalities like yoga, dance, music, art therapy. So a combination of evidence-based with that contemplative practice. They continue to see their individual therapist along with family therapy if that's something they've opted into. And then they have access to psychiatry and medication management if that's clinically appropriate. Our program is usually about 10 to 12 weeks long in duration. And then once they're ready to discharge from our program, our discharge team works with them to find resources and make sure that all those are in place when they're ready to step down from our level of care. I want to pause there. Any questions about how the process through Charlie Health works? I'll save plenty of time for questions, but I do want to jump into just a couple results of our outcomes. So we partner with external universities to collect our data. And most recently, we've been partnering with Yale University and University of Pennsylvania. And what we're doing is we're collecting outcomes, we're collecting the data during admissions, all the way through our treatment program, so that 10 to 12 weeks, and then up to a year every 3 months post-discharge. We're using, you can read through all what data we're collecting here, but PHQ-9, GAD-7, Q-5, a bunch of different qualitative and quantitative measures. And what we found are pretty significant outcomes. We've been doing our outcomes for the past, let's see, almost 4 years now. And it's really exciting to see the trends here, but we see a huge decrease in depressive symptoms and anxiety symptoms, a decrease in suicidal thoughts and even self-harm frequency. And something I want to note here that you can see is that that first bar is during the admissions, the second bar is at discharge, and the third bar is 3 months post-discharge. So we're actually seeing not only a decrease at that time of discharge, but staying stable even 3 months after discharging from Charlie Health. It's really exciting here. This is my favorite to share is just our readmission to a higher level of care rate. The standard average, industry average for readmission after 3 months post-discharge from an IOP is about 20 to 30% of clients coming back to IOP or a higher level of care. What we found at Charlie Health is that after post-discharge, only about 3.3% of our clients are coming back to an IOP, any IOP or any higher level of care. And this is pretty significant. When we first started doing our outcomes, we were at an 11% return rate to IOP or higher level of care, and that was still significantly lower than our industry average, right? But we've been able to continue to reduce that over time, and we really attribute that to the way that we apply feedback for our program and continue to evolve not only our treatment, but the way that we're matching folks together with their individual therapists and also in their groups. So really excited to see these outcomes. And then the last thing I want to share is just our satisfaction rate, right? We have a very high satisfaction rate from not only our caregivers and guardians, but also our clients themselves with their personal therapist. They're just a very high satisfaction rate. So I want to share this. And I can also drop in the chat. We have all of our outcomes listed on our website. So I'll drop a link here so you can review all of those outcomes if you want to explore those more. And then let me pause here. I think I stopped sharing my screen, but any questions, I'll look through the chat as well, but anything coming up, questions about the program? I know Beth mentioned insurance. We are in network with almost every commercial insurance, including Kaiser Northwest, although the referral has to come from a Kaiser team member themselves for Kaiser members. CCOs, we're in network with almost every CCO, all the major ones in the Portland area. I can drop a whole list of all the CCOs, but curious if there are any specific commercial plans that you have a hard time placing folks with.
I think,
Yeah.
Did you ask commercial plans that we have? Yeah, I mean, for me with youth, it's all of them. There's just not a lot of providers. That's the problem I run into, especially providers willing to take youth who are like have recently been in crisis or maybe have higher needs. Yeah.
Okay.
Yeah,
Yeah.
this would be a good resource for some youth. Also thinking about, I'm working behind the scenes, going to work closely with Emily and Emma that like how do they, when kids might be in this program, if it's not working for them or they complete it successfully, what program can they hand them back to, and how do they at discharge connect with IIBHT or something that's face to face, or could this be a stopgap for kids who are waiting for some of those? We know not all youth do well with telehealth, but
Right.
it is an option for us to try, and they have immediate access, especially thinking about supporting the families. I also think, Emily, it might be Marlena put TRICARE in there. So yeah, TRICARE. And then there is a question, Emily and Emma, about co-pays, and does this add up with the private insurance and those things? Because a lot of our families don't want to take on those extra costs or don't have the financial. Yeah.
Yeah.
So
really
any
good.
thoughts on those two?
Yeah. Quick, I'll go back to the TRICARE. Yes, we're in network with all the TRICARE so that we are good to go there. As far as the co-pays go, we can work with family members depending on what their copay looks like. We have options for financial support, whether that's payment plans or maybe looking at a financial hardship scholarship option for families. So we do that case by case and work with them. We really try our best to make finances not an issue for families. So if you have a family that has commercial insurance and they're concerned about a high copay, our team can work with them and try to find a payment plan that works for them. We do not charge for the assessment, so they can still go through our assessment and talk with a financial counselor prior to moving forward at no cost to the family. We make sure to communicate that all up front so that there's no confusion when starting the family or starting the program. If you have a family that you have in mind and you want us to run verification of benefits prior to even doing the assessment, just to see what that payment might look like, we can absolutely do that. So we can even push the assessment out and run verification of benefits first.
Asking a little bit about the scholarships, like does that actually cover and how available are those? Because we know that sometimes we say scholarships and then they're like, well, they're no longer available, or we only maxed out.
Yeah. So that's entirely case by case. So it's really dependent on what the family will need. And the financial hardship scholarship doesn't mean that it's going to cover the entire cost. It just means that it can reduce costs for family who have high copays. And that's our admissions team and our financial counselors work together with the family to find what might work for them. As far as referring out goes, so if a client is going through our assessment and it's determined that maybe we're not the best program for them, maybe they need a different level of care or an in-person program or a different specialty program, our team will work with them to make that referral and find a program that's better suited for them. So if Charlie Health is not the best fit, we don't put that back on the family. We don't put that back on their providers. We help connect them to the resource that is going to be the most appropriate fit for them. And the same goes if they're participating in the program and something comes up or it's determined, this isn't a good fit. I tried it out for a couple weeks and virtual is not for me. That's completely fine. We'll work with that client and be able to help them find a program that is better suited for them. Same with discharge. Our discharge planners are really working from the beginning of the program to the end to make sure those resources are in place when they're ready to discharge from the program, because we understand there are long wait lists for outpatient programs and resources. So our discharge planners are really helping at the front end to make sure that those resources are in place at the end. But we can always help clients find a different resource if Charlie Health is not working for the family. Okay, I see that there's more.
Yeah, one of them is just about Kaiser. So you said that Kaiser Permanente, that they have to have someone internal to refer it. So if these guys are out in the field, would they call Kaiser then and suggest Charlie, or would they call you and then you guys would call Charlie, or how would that work?
Correct. And I'll just ask, how do you work with Kaiser right now? Are you calling their crisis line or their mental health referral line when you have a Kaiser member?
This is Tammy from Polk County, and what I've tried to call Kaiser Permanente directly, and I've always been told that the client needs to come in person and request to be referred to us. And typically when the family's with us, they're not wanting to go to Kaiser to request something in person.
Yes.
It's a big barrier.
Yes. So Kaiser's process is they always want the Kaiser member. They have an internal process where the Kaiser member has to be seen by their internal team to be referred out. So I have two different numbers I can share if your team doesn't have this, but there's a mental health referral line where the Kaiser member can call in and request a service, whether that's IOP, higher level care, whatever that might look like. And then the Kaiser Mental Health Referral Center helps facilitate those referrals. So that would be the number that I share with clients to start that internal process. They can always, and you can always request our program, but it is up to Kaiser to choose the placement for the client. And they might, if they haven't already tried their internal IOP, they might have them try their Kaiser IOP prior to anything external, if the client has the ability to do that. Now, if they're needing virtual or a specialty program that we offer and Kaiser doesn't, that's when they'll refer out to us. So I can provide those numbers. They also have a Kaiser crisis number that they shared with us to give to clients who are in immediate crisis as well, that I can share with your team.
Okay, thank
So
you.
it's up, so Tammy, it does sound like it's up to Kaiser. They may have that, maybe a barrier for some families if they have to come in and there's not one close and they have in your area and stuff. So it sounds like it's possible, but it may not alleviate the need for that. Can you remind us also about, there's a question about psychiatry. You do have psychiatry available. What does that look like? Are they comfortable? Do they actually prescribe medications over by telehealth? Because we've heard sort of
Yes.
different things.
Right. We don't prescribe any controlled substance or controlled medications yet, but we can prescribe some things, and I can get you a list of what we can and cannot prescribe. So we can do medication management. This is really, again, depending on the client's insurance. We do have Oregon psychiatrists, and it has not been a problem to get folks in. Usually they are seeing a psychiatrist within 2 weeks of starting the program. If for whatever reason they cannot see our internal psychiatrist, we'll work again with just outside providers to help schedule those appointments. And if it's someone that's needing medication management in our program, our discharge planners make sure that they have that set up post discharge as well. So they have someone who can do their medication management after our program.
And just a reminder to you all, if you do have youth who are have a PCP who may not be comfortable with prescribing psychiatric medications, there is Opal A and Opal K available to Oregon pediatricians to be able to call and consult with OHSU, with the child and adolescent psychiatrist. So that line, they have hundreds of doctors who call in to get to be able to consult with an expert in psychiatry to help alleviate some of the worries they might have. So that's also something just to put in your back pocket. Opal A is the Oregon Psychiatric Access Line for adults, and then Opal K, same thing, but for kids. And that's through OHSU, and it's highly popular, but it also helps to offset that kind of fear and risk that some pediatricians or PCPs may have when trying to when a youth is needing. So just another example.
I wanted to go back, Beth, to your question about our ability to refer back to your team. If you're sending in a referral, whether it's a placeholder because a client might be on a wait list for another program, or you just want to make sure the client comes back to you, sending in that referral, we will always check to make sure, or check to see if you want that refer back at the time of discharge. Our team can also communicate care updates with for clients that you are referring. So if you refer a client and you want weekly or bi-weekly updates on that client, we make sure to get the ROI signed at the point of receiving the referral, so that we can communicate those updates and collaborate and care along the way. So we'll always check and see, do you want this to be referred back to you? Is this a case that you want updates on? And our team is happy to communicate as little or as much as you all want.
And that might be a good to think about for stabilization services. So these guys, a lot of them go out and do the first initial crisis de-escalation, but for youth 20 and under, a lot of them will be enrolled in stabilization services. So maybe getting them into Charlie Health, like maybe this is an option for some of those families to enroll and get ongoing support, but maybe they need IIBHT, or you guys are decided that they need day treatment. So you can also just put on the referral, like, hey, can you coordinate back with us, or they may need day treatment, or this is where while you're doing your assessment. So just things to think about as we're exploring these relationships. I see some other questions I didn't get to keep up because I was talking.
I think that Emma has answered most. We are in network with UHC. Is there anything in here I'm missing? Anyone want to come off mute? I'm going to drop our the ways to refer. I didn't really cover that, but we have a few different ways to refer, and it's really up to you on what works best for you and the client you're referring. But you can either call our admissions team directly and go ahead and schedule that assessment while on the phone with them. We also receive fax if you enjoy faxing. And then we have a very simple online referral link that a lot of providers prefer to use because it allows for Charlie Health to make that first call. So the family or the provider or you do not have to pick up the phone and actually make the call. So I'll drop that link in here as well. With that link, you can also add any notes. So if you wanted to mention this is a client that I want referred back to me, or I want these care updates, you can put those in the notes as well. And it's just simply asking for the client and family's contact information, insurance information if you have it, and just pretty generic demographic information. I'll put that.
Emily, one of the things you mentioned when I met with you was these, I think it was, I don't know the name of it, but for the summer, maybe you had some special programming for the summer that these guys might be. We are having a huge increase in crisis calls across the state for youth and for youth specifically. We've been doing some check-ins with all of the different counties. It seems like everyone is experiencing an increase in youth crises right now. But you had mentioned something about specific groups, and like if you could tell us anything about some of the types of groups and the bare minimum for somebody, if somebody is enrolled in Charlie, what's the bare minimum of contacts? Because I feel like you said that a youth could go to 2 groups a week and not do anything else, or they might I can't remember exactly.
Yeah.
If you can just.
Yeah, no, thank you for bringing that up. So to touch on our specialty programming, first of all, we have over 150 groups running a day. So lots of amazing groups for folks to land in, but we do have some specialty programming. The one that Beth is referencing for our summer, we always do a summer program, and this year it's focusing on students ages, I believe, 11 up to 23. So adolescents and young adults 11 to 23. It's our Reset Recharge summer program that focuses more on executive functioning and social skills, really meant to help prevent that annual back to school crisis for students, right? And give them a safe place to come together and learn some skills over the summer. So that this is still an intensive outpatient, so it's still IOP, but specifically geared for students to prevent that annual back to school crisis. There's a little heavier focus on our contemplative and experiential programming in the summer program. So typically our traditional IOP is 3 hours, right? 3 days a week. This is the same, but instead of the way that our groups run are usually evidence-based therapy. So let's say they start with an hour of DBT skills, then they move into that experiential and contemplative hour, and then they finish with another hour of evidence-based. Maybe it's processing or coming back to CBT or some other evidence-based program. This program has a little bit heavier focus on the contemplative and experiential programming. So you might start with art therapy and then move into DBT skills and then finish with another contemplative practice like yoga or mindfulness. So it feels a little bit more summer campy. It's really the intention. And yes, Reset Recharge. And when I do a follow-up email, I'll include a flyer for that specific program. We just launched it June 3rd. So if you're referring someone to that, you can just put that in the notes as well. Or when you call, you can say I'm specifically referring this client for their Reset Recharge summer program. But that can be just a really safe place for kids to come together in the summer. Another specialty program that we just launched back in December, which is really exciting, is our maternal mental health program. And this is the one that I mentioned goes up a little higher in age. So this goes up to age 40. And it's specifically for moms experiencing postpartum depression or perinatal mood and anxiety disorders. The program itself was born because we were just hearing a need from the community of there was just a lack of resources that specialized in postpartum depression. So our team came together with some amazing clinicians in the Texas area and developed a program and put our clinicians who are involved in this through a training for our maternal mental health. And it's been very popular. And so I'll include a flyer on that as well. But those are 2 of our newest specialty programming. We also have specialty programming for the LGBTQIA+ community. We have a lot of neurodivergent specific groups that adapt our processing and our programming for the needs of those groups. We have BIPOC support, BIPOC groups now, closed and open. So lots of different specialty programming within the IOP, and all still intensive outpatient. So the minimum amount of engagement for IOP is 3 groups, 3-hour sessions. So that would be the minimum amount. They can always opt out of family therapy if that's not something that they want to participate in.
Questions from you all? Yeah, anything for supporting youth with autism? I know you said neurodiverse, but any ASD groups?
Yes, we do. Mhm. We can
I
support.
also, I'll keep asking you questions all day, but I don't want to, if other folks have. I was just curious, what types of youth, what kind of programming does not translate well for your telehealth? Like, are there certain diagnoses or things that you guys have decided this isn't a great match given their presentation? What youth would those, or young adults topics would those be? So these guys know that it wouldn't be a great referral or not to refer those youth.
Yeah, clients do need to be able to participate virtually. So if a client is not able to participate virtually, that would not be the best. We would obviously not be the best fit for them. But we can always do an assessment. And if it's determined through the assessment that this isn't going to be great because of that engagement piece, we can refer out to that. Another big one is eating disorder. We are not a primary ED treatment, but we can still work with ED as long as they're stable and clinically appropriate to be in a virtual setting. So we might work alongside an in-person RD or somebody on their outpatient team. But if it's a client that's needing intensive ED specific treatment, we will refer out to our community partners for that. And then we can always be that discharge resource for them when they're ready to step down in care and focus on the mental health aspect of the ED. Similar with SUD, we are primary mental health, secondary SUD. So we can work with folks who are experiencing substance use disorder. But again, we'll be focusing on the mental health piece of it. So if they're needing detox or SUD specific treatment, that is when we will refer out to our community partners. And again, similar to ED, can be that resource for when they're ready to discharge to a virtual setting. So those are the biggest ones that we see. Emma, any other notes, anything that you would mention or?
No, I think that kind of expanding on the ability to engage. Sometimes active psychosis is a key indicator that they might not be able to engage on a virtual platform for 3 hours. So that's kind of one of the other pieces that we might have to refer out for.
And the 3 hours again can be split between the youth and their family. Is the one of the hours, or is it separate, or does the child have to commit to 3 hours and then everything else is extra?
Correct. So it's 3 hours, 3 times a week of group, and that would just be the client. So the client with their group. Now, if you have someone that's hesitant because they feel like that's a lot of treatment, and you feel like it's still clinically appropriate for them to have this level of care, we can try it out. I tell folks, give it a couple weeks. If it's not working after a couple weeks, no worries. We'll find something. We'll look at other options and find something that's a better fit. I know that it can sound intimidating for somebody to experience 3 hours of 3 days a week of treatment, but the reality is the way that we are creating these groups, they're very engaging, and clients are wanting to show up not only for themselves, but also for their peers that they're making in these groups. Our Charlie Health is really meant to create these strong connections and build community within groups. So we do see a very high engagement and attendance rate. We've actually been sitting at about a 91% engagement and attendance rate for the past 2 years, meaning that 91% of our clients who are enrolled in IOP actually show up for those appointments. And we have such a high engagement rate that clients also want to stay connected after the point of discharge. So we have an incredibly robust alumni program and services. And actually, I'll drop a link in the chat because it's pretty phenomenal, and we list them all online. So I'd recommend checking this out. But clients are able to stay involved even past the point of discharge at Charlie Health through ongoing groups, newsletters, events. So it's really big on creating that connection and community. And yes, there are breaks between each hour of group. Thank you, Emma.
Any other questions for Emily and Emma about this program? Could you guys see that, like, a connection with some of the folks, or this might be a good option for I also just keep thinking about those young parents who are in their 20s when you guys go out for a family. I'm guessing, is there a list of all of the groups that you offer, or is that not posted? I mean, one of the things that I keep thinking about is the support might be for the parent, might need need to enroll in the intensive outpatient, not just thinking about the children as being the primary client that would need it.
Yeah,
I'm just curious.
Yeah, I can send a list of some of the modalities that we specifically work on and see at Charlie Health. They can also participate in our free parent support group. So if they're not ready to commit to an IOP and they just want a free resource, we have a number of free parent and caregiver support groups. So I'll include that in our follow-up as well. But that can be a great place to start for parents who aren't quite ready to be in an IOP, but need some kind of support.
Great.
Maybe they have the client in the IOP and they want them to focus on that and support and family therapy, but they need that additional connection as well. So I'll include that in my follow-up.
I think that would be great.
Yeah.
Anything else from you all? Well, I will make sure that we get, when you send the email, we'll make sure that these guys all get your resources. And I just thank you for coming back and look forward to making some referrals, but also connecting with you all about what are like Oregon, these guys offer a lot of different services that could be utilized as a step down if you do have. Do you have an idea of how many youth in Oregon are utilizing this service? I'm just curious.
That's a good question. I can get a number and follow up with you on that.
I'm just curious.
Yeah, I'll ask our clinical director for an updated number. Yeah,
that'd be great.
Yeah.
All right, and they put their emails in the box. So thank you so much, you guys.
Yeah, and please reach out if we can help answer any questions or any feedback too, whether it's constructive, positive. Please feel free to provide that. We want to make sure we're being the best versions of ourselves for our clients, but also for all of you. So please feel free to share any feedback that you have.
Yeah, and if anyone hears anything about Charlie Health, whether it's a rumor or not, if you do want to pass it by, there's been a couple things I've myth busted with Emily and Emma, so I'm happy to investigate or reach out to them if it has to do with an OHP client as well, or access or something. They've been very open to investigating and making sure we are doing what we can to get folks served. So.
100%.
All right. Well, have a great week. Thank you.
Thanks so much.
Bye.
All right. Helpful, not helpful? Was that something that you guys actually think might be a resource at sometimes for youth? Has anyone used Charlie Health already? And has anyone have anything to say? Or I see a couple heads nodding, but what are you guys hearing about it? I mean, did your clients have good success or?
I've heard mixed feedback. Usually the mix is if people are just find that the online stuff doesn't work for them. Yeah. I also did hear I don't know if I want to share this or not, actually.
Okay, that's okay. Yeah. I think it is difficult.
I guess I have heard that maybe like things aren't how do I say it? Maybe they're not like the things that they're saying that they offer, maybe like it's not totally like everything that is being offered to people, I guess is the best way to say it.
Yep. Well, and that sounds familiar. I mean, right, like, so yeah, if you do get feedback though about specifics, they are really open to hearing it because I think that their intention is to remove any of the barriers. I do like that it does sound like they're pretty quick to do an assessment and try to get people enrolled very quickly is one of their things that I liked about it, but I've heard mixed reviews. Of course, we know a lot of youth can't handle sitting in front of the computer for that long, but they do try to balance therapy with movement and other things. Anyone else have anything that they experiences or have heard?
I will say they're really quick. Like you'll put in an online referral or give them a call and they're just like on it, and they like send me an email and say I've connected with this person. And
Oh, good.
yeah, usually for me it's been mostly like college aged kids is who I've been like, that seems to work better for them with the online, stuff. But yeah, they've been really quick at, reaching out to the person and getting them started, and or at least explaining their program.
Yeah, I also think just thinking about how you might be able to, if these are any resources that might click with a parent, right? So maybe a 12-year-old's not going to sit in front of a computer, but is there some sort of support or something that they could offer to the parent? And it sounds like there are classes or support groups of some sort without the whole intensive IOP. Of course, you guys know, a lot of you, is that we do similar services in Oregon. IIBHT is sort of the same setup minus the groups. It's more individual and family focused, specific rather than group therapy, but that's all in person and in person and in home whenever, but it still is, it's not as intensive. This is really, a lot of hours, but we do have something in Oregon. So just thinking about if kids, making sure that they know too about how to get a hold of other services or step youth that might be accessing their services into other programs you all are offering at your agencies might be helpful. So we only have like 9 minutes because I like to end 5 till, but I did want to just see if anyone had any topics or anything that you guys wanted to ask the collective brain here, the beehive, any questions that you all wanted to put out there and float by each other to get any feedback on. Lauren and I have been meeting with all of the CMHPs to sort of get a temperature take around stabilization services and where everybody is at. So it's been nice to meet some of your teams in person. And there's a lot of thought going into building out stabilization services. So here's your chance to ask question. Yeah, IIBHT has a website, and the website has a list of all of the certified providers. There's 22 IIBHT providers. It is the providers, it's per CCO. So the providers you'll see on the list, it'll say who's their CCO, and then it'll tell you who the providers are in that area. Nova, did you raise a real hand?
I did. I was just curious, and I was going to type it, but I was just curious if any other agencies or counties are doing the receiving center / stabilization in-house services for the 15 to 18 or 17-year-olds.
For 17-year-olds. So future state, like you mean?
Yeah, like are anybody talking about doing that in their spaces?
Yeah. Well, let's see. Does anyone, and Lauren also just got back from interviewing all 36 CMHPs and talking to them about their plans around the crisis stabilization centers or crisis receiving centers. I don't know the language yet, but your question is, are any of those that are in process, are they going to include any kids younger than 18? Is that what your question is? Like, if they're going to include? Yeah. Anyone on here that wants to, is anyone planning on including children in future state first? Yeah, Miriam.
Yeah, so we're in the middle of a soft implementation of crisis receiving center. We're not serving youth in this first phase, mainly because we have a lot of logistic questions and concerns about consent and notification and things like that. Our intent was to serve youth in a later phase. We're pretty concerned, though, with the new draft OARs that just came out. Our physical space is not going to be adequate for that. And so that's not saying we for sure won't do it, but at least if those OARs go through in their current format, we wouldn't be able to serve youth in our current building.
There's a lot of, and Yeah, thanks, Miriam. There's and it's not just Oregon. I think there's a lot of there's federal laws around co-mixing populations, and so there's a lot all the way down to, and I don't know enough about all of it, but even down to how many feet and what building and how many doors. So there are things in there that you'll have to think about. But Lauren, yay, there's Lauren. She's our expert.
Nova, I think you asked the question. I was just taking a quick look at who's in the room right now to see if anyone can speak to it, but our partners at Lane County might be good to speak to. They are planning on having an entire wing for youth in the facility that they are planning. Deschutes County, while they do not serve youth right now, I mean, they do if they have no adults in the building are able to kind of separate, but they would ideally have a wing that is for youth if they can get the funding. They plan on doing that. Trying to think of anybody else who's planning on serving youth in some way, shape, or form, but those are the two that are jumping to my mind right now that might be good resources. If you want, feel free to reach out and I can connect you.
I didn't realize it was coming down, but yeah, Coos Health and Wellness, we're moving our children's team into another building, so we'll have our IIVHT and MRSS and outpatient team based in a building that's a couple blocks away from our main building.
But you're not going to be having any youth staying physically in that, like in 23-hour.
Oh,
These are
no,
23-hour bed. Yeah.
okay, never mind.
You don't need to worry about those laws if you're just office space, but these are for, yeah. So Lane and Deschutes seem like Nova, that's your best bets for right now, but Miriam sounds like she's also thought about it. It might be a good one to ask more questions too. The only other thing I can think of for you guys is that they are redoing the outpatient rules right now, and in the community engagement session, I think there's actually one right now that are missing, but they are updating the outpatient rules. I know it doesn't impact mobile crisis, that first initial 72 hours, but there may be some implications or changes that are made to the outpatient rules that may change workflow or things for stabilization services. So I'm just keeping my eyes on those to see what we as a group want to do once those rules are finalized, if it's going to impact us positively or if we need to think outside of the box about what we want stabilization services to look like as far as paperwork once those changes are all made. So I'm just letting you guys know I'm open to suggestions and ideas. Those are still in they're posted, but they're temporal. So I'm waiting to see what the final, because sometimes, you know, by the time we're done with that engagement period, they look very, very different. So those are the outpatient, and it's for entry and assessment and service planning, sort of the documentation to allow rapid access for people to be able to get the services they need without having to wait for that documentation to be as completed as we have made it in the past. So it's a nice, best way I can summarize it. So more to come on that. Yeah, Nova.
Another random question. This isn't specific necessarily to
All
youth,
right.
but has anybody got all their ducks in a row with actually doing enhanced billing yet? Like, are you actually doing it? Are you performing that? Are you, do you have a document that I could see? Basically,
For
are you?
For MCIS, for the enhanced billing for MCIS, as you're asking? Yeah. Lauren, do you know if anyone has? I know you had just talked about that too with Luke, if anyone has submitted any claims yet for that, and if you know what counties they are?
Yeah, so far I'm not aware of anyone who's actually been able to start billing. What I have heard from a couple is that their biggest barrier right now is getting some updates to their EHR to then be able to seamlessly bill. And that seems to be like the last piece that is preventing folks from billing. So if I do hear of anyone who is actually billing, I will let you know. But as of right now, I'm not hearing of anyone. Intention to, just having a barrier to that.
All right. Any other questions about any, long as Lauren's here? But any of the other crisis system pieces? All right. Well, thank you for showing up today and you're interacting with Charlie Health. I'm open to suggestions for topics for the next month when we meet. If anyone has a topic, I know that when I've been visiting and visiting the CMHPs, there's been different topics that have come up where like, oh, that'd be a great learning collaborative topic. And so people, I just want to encourage you guys to know that this is your space to be able to brainstorm ideas and talk about things with all of you guys are the experts. It doesn't need to be me talking and filling space the whole time. It's really meant for you guys to utilize this space in whatever ways make sense to you. So if you do have topics, shoot them to me and we can prioritize them. We can do breakout groups. We can do whatever is going to be helpful for you all as you're getting closer and closer to providing these services. So if you have a good topic that you would love some dedicated time with a small group of people, let me know and we can put that into any of the agendas. So I hope that you guys have a good month. Next time I see you, it's going to be July already, unless you come to office hours. Office hours are on next Monday. But otherwise, I will see you on July 8th. So have a good first month of summer. Bye, everybody.